Hello, everyone, and welcome to Greater Living. This is the time where we talk about something that affects all of us, our health, and we pick a topic, and today's topic is diabetes. And we're talking with Dr. Ruth Horowitz in a moment, particularly about adult onset diabetes, particularly about diabetes type 2, which I know a lot of people are concerned about. But first, we just want to take a few minutes, and I know you know this woman too because she's been amazing at GBMC, and we want to just take a few moments for you to meet and kind of give a round of applause, as it were, for this year's Compassionate Caregiver.
Today, we're going to honor the top 5 honorees. They were selected from over 100 actual submissions that went in over the last year. We're going to hear about the compassionate, empathetic, selfless, humble, loving, and caregiving work that each of these honorees and individuals have done and are being honored here today. Tara Archer, volunteer for Gilchrist Kids. Dr. Chris Greenewald, Greater Baltimore Health Partners hospitalist. Carolyn Inslee, Executive Assistant, GBMC Philanthropy Office. Corey Joyner, GBMC Security Officer. And Lisa Brengle Kruger, RN, Safe Nurse.
She lights up herself when she comes to the unit because she's so happy to be here. And she lights up the unit with the love of her role as a volunteer.
He has an extraordinary bedside manner and makes everyone he encounters feel important and cared for.
She is a giving and caring person, one of the most generous hearts I have ever seen.
Corey has a warm, welcoming, easygoing demeanor. He treats everyone with respect, dignity, and patience.
Lisa is full of creative ideas and always attempts to provide the best care and complete the examination, no matter how impossible it may seem at the time.
I would like to congratulate each of the top 5 nominees, and reading some of the stories, they were just amazing. So congratulations to all of the nominees as well as the top 5. And it is now my pleasure to announce the 2018 Nancy J. Petrarca Compassionate Caregiver of the Year Award. The award goes to Carolyn Inslee.
I cannot believe it, but I thank everybody. And GBMC is a wonderful place. And there's so many stories that we haven't heard yet. And I hope you'll all nominate. And I'm very grateful. And thank you, Maria, for watching.
Yes, congratulations, Carol. And I think all the nominees were worthy, but there only has to be one winner every year. So Carolyn Inslee is our compassionate caregiver for the past year. So congrats to her. Now we get on to our topic again about diabetes, something that affects so many more Americans than I think most of us even realize. Dr. Ruth Horowitz is here again. She has many areas of expertise, and diabetes being one of them. She is the chief of endocrinology at GBMC. And we were talking about how many Americans are affected by diabetes, and right now I think the count was more than 30 million.
Correct. That is people who are aware that they have diabetes and people who are not yet diagnosed.
So, and that's 1 in 10. So we're looking at a whole group here, and the odds are that, maybe 2 or 3 of you may get diabetes if you're judging by those odds. So it's something to be aware of. And I think it's something, too, that as adults we think about, and we hear a little bit about how we can prevent it. Are we always so good about doing that? Not necessarily, but as we get older, I think we think about it more. So let's just start with the very basics, and I know that John also got into this too, but so let's just explain what it is. We know it has to do with sugar, right?
Glucose,
and insulin
yeah.
levels.
Yes.
So glucose and insulin levels. So it's our little pancreas, right?
Right. So your pancreas produces insulin, and insulin is basically the the force that moves glucose into your cells. And glucose is broken down by the body as your energy. It's sort of like the gasoline in your tank. In many forms of adult onset diabetes, you make a lot of insulin, but you're resistant to it. It doesn't work particularly well. And so your body ratchets up that amount of insulin, trying to improve your glucose and move that glucose into your cells. But eventually, you can't keep up with the need. So the glucose levels build up in the blood, and the insulin isn't able to move enough of it in.
So, and does this happen because A, we're getting older, or, and this may be a combination of things too, B, we're abusing our bodies in such a way that we're just pounding with so much sugar that the insulin can't keep up with it, or the cells become resistant to it?
It's a combination of things.
Okay.
There are genetic reasons why people are predisposed to developing diabetes. And then it also has to do with what we deliver. If we're eating in a fashion that provides a lot of glucose all at once, you can overwhelm your system. And also, if we are, the heavier we are, the more obese we are, the more resistant we are to the insulin. Having an unhealthy lifestyle, not exercising, not eating properly, not getting sufficient sleep, as Rebecca mentioned, all these things increase your insulin resistance and increase your risk of developing diabetes.
Okay, not to pound on the guilt, it is possible for someone to live a very healthy lifestyle and still develop type 2 diabetes.
Absolutely. I mean, there are some genetic forms of diabetes where even if you're not overweight, you are prone to developing, do have an underlying form of insulin resistance. And even with good lifestyle, without medical management, you may still develop diabetes.
Can we tell this by looking at our family history, or sometimes we just don't know?
It's a combination. You know, diabetes is very genetically predisposed. So if you have half a dozen people in your family with diabetes, there's a pretty high likelihood that you're at high risk for developing it. There is some forms of type 2 diabetes that present at younger ages with adult onset diabetes, and that history is also very suggestive of a genetic underlying. So if you had, parents or a mother or father who developed type 2 diabetes, say in their 30s, there's a good chance that you may have one of this genetic forms of diabetes and is not overweight or obese.
And I would imagine by the time you see someone, they've already got symptoms, right? That's why they're coming to you. And do you always go to an endocrinologist?
No, first question, most patients who come to see me have already been diagnosed with some problem as either prediabetes or diabetes. Unless I'm seeing a patient for another reason, I might see a patient who has thyroid disease that I make the diagnosis of their diabetes. But as a specialist, I tend to see somebody after they've already been diagnosed. What was your other?
That was I think you looped it all in there together.
Totally.
So they've been diagnosed and they come to see you, and you are helping them manage.
Correct. I mean, does everybody need to see an endocrinologist? The answer is it's not possible for everyone to see an endocrinologist. With 30 million type 2 diabetics or diabetics in the country, there are not enough endocrinologists to see every single patient. So most primary care providers can provide excellent care for their diabetics. We tend to see the patients who, despite the best efforts by the primary care provider, is still not achieving their glycemic targets, and that's when they send us to us.
So they're tougher cases that come through your door.
And then some patients just sort of like to see, whoops, just lost my thing. Some patients just like to see a specialist. They want to make sure that they're doing the right thing. And we do see some patients on self-referral if they have a known diagnosis, but generally we want to see the tougher cases, those ones that are having difficulty, that need that expertise, that above and beyond the basics.
And what makes for a tougher case? Just the individual makeup?
Sure. I think that a lot of it has to, unfortunately, do with compliance. I think that patients are often resistant to following all the rules. I think the transition for many patients from oral medication to injectable medication is a difficult transition. When a pill doesn't work anymore, or they've been doing the best they can, but they need that sort of next step, a lot of primary care physicians find it difficult to sort of corral their patients to go to that next level. And I think that also seeing a specialist sort of pushes patients to follow the rules a little bit better, diet better.
Take it more seriously.
Exactly. I think that having that extra credentials behind my name often gives me more weight to the recommendations that the primaries are really trying to get their patients to do. So
for the stubborn, non-compliant patient who may come through your door, what sort of tactics do you use?
So I love it when my patients say, "You're going to yell at me," and I was like, I don't yell at anybody. I think that how I personally approach my patients is with realism. I say to my patients, and I start it with, I'm not trying to be rude, but what are you willing to do? It does not work for me to give you a laundry list of things that you're never going to do. And I figure out what they're willing to take, what they're willing to do in their lifestyle, how they're willing to adjust things, and I start there. I work with what's realistic. And then from that point, when the patient starts to see some improvement, then we can keep sort of moving it up. I'm not going to give a patient instruction to take insulin 4 times a day when they're never going to do it. What's the point?
What is not motivating them? I'm curious. Is it that the symptoms are not severe enough, or that they just don't believe what could happen in the end?
I think that's
is
part
around
of it.
the corner.
Absolutely. I think patients are in denial. They really don't want to see what's going to happen. And until something horrible happens, which is unfortunate, then they also often see the light at that point, and then they become very committed to their diabetes. I think that's part of it. I think it's really hard to be a diabetic. You really need to be very knowledgeable about diet and exercise and monitoring your blood sugars and staying compliant. And people get frustrated and they give up. They try hard, but things are not perfect. They do what they're supposed to do, but their blood sugars are still not where they need to be. So people get discouraged. And then there's fear. There's fear of medication. There's fear of injection. They may know somebody who had some unfortunate complication of their diabetes, and they associate that with the medication rather than the control. And I've had patients that I've had battles with where I say, no, it's the uncontrolled diabetes that made the person have a nerve problem or an eye problem, and that if you controlled your diabetes with the insulin, that will make it better. It wasn't the insulin that made the person have the problem. And it's an educational thing, and it's just sort of fighting all of that.
So when we come in, or when a patient comes in and they see you because they just need that extra help and getting through a difficult case of their diabetes, whatever it is, what is their prognosis if you can convince them, or they decide themselves to be really careful, to be really particular, to stay on the regimen? I mean, what's the prognosis, or is it so individual you can't really say?
Well, the studies have shown that...
And I'm going to ask you the other way, too.
Sure. Studies that show that there are a variety of different studies that show that improving glucose control clearly improves your risk of developing certain kinds of diabetic complications. So microvascular damage, which is the small blood vessels, which lead to things like kidney damage and nerve damage and eye damage, absolutely are reduced significantly with reducing glucose control, with improving glucose control and reducing glucose levels. The macrovascular, things like heart disease, stroke, they don't respond as well to glucose control. We now have a variety of medications that actually have been shown to improve cardiovascular outcomes. So if you use them to control your blood sugar, you may also reduce your macrovascular complications. So it makes a huge difference. Poor control accelerates the complications that we can see. And those, as I mentioned, nerve damage, eye damage, kidney damage are the small, tiny vessel complications. And then the macrovascular disease, which is heart disease and stroke, are the other larger.
And I think, too, for a lot of people, we hear that someone has passed away from heart disease or stroke. What we don't know, and maybe never will know because we might not know them, but is that they had diabetes underneath all of that. And so maybe people don't realize that that's so connected.
Right. And then also with diabetes, many diabetic patients also suffer from hypertension and high cholesterol. It's sort of the triumvirate. And controlling blood pressure and cholesterol are critical in reducing those large vessel, the macrovascular complications of diabetes. So you can't just treat the glucose and ignore the other things. I sort of say to my patients, it's like a 3-legged stool and you're sitting on the top and you have to treat all 3 of them or it falls over.
So it's like a job.
It's absolutely
a job. It's really quite complicated. Can you turn back if you've I'll talk about prediabetes in a moment, but if you've got full-blown diabetes, however you phrase it, and they're seeing you, can they say, if I do all these things, can I become asymptomatic, or can I lose this diagnosis?
Sure. As Rebecca was talking about earlier, even people who get their glucoses under control or even have, say, bariatric surgery or make some major lifestyle changes and improve their glucose control into the normal range, You can do that, absolutely. You can be what we call diet controlled or lifestyle managed and not be on any medication. But I never say that a patient is cured, because you've got that genetic predisposition. And if for some reason you stop exercising, you stop following your diet, your glucose levels are going to go back up again and you are going to develop problems again. So it's an ongoing.
So when you're committing to a lifestyle change, you mean forever?
It's lifetime.
As
It is
long
lifetime.
as possible.
And I have seen many patients that I saw in the hospital with new onset diabetes who have terrible glucose levels, and then they get all their education, they really start doing everything, and their glucose has come down into the normal range, and they're great for a while, and think, okay, I'm done. And then, 6 months later, they come back and their blood sugars are back up again. It's constant surveillance. It's never a done deal.
Yeah, and it's complicated. So it's like, if, let's say you're just simply trying to lose weight. That is complicated enough,
Very
right?
difficult.
So to understand how it all works and how one thing affects the other thing, that's a really hard thing for a lot of people. And so I would imagine that there needs to be a whole village surrounding them, supporting them along the way.
Absolutely. Studies have shown that people have better compliance when they have family involvement, when they see a diabetes educator, a nutritionist, a physician, they are in exercise and they work with, perhaps a trainer or are on a regular schedule. All those things absolutely improve long-term glucose control.
All right, we do have a question from the audience.
Okay, so we have several questions.
Okay.
There have been a few about diet. So do you have any suggestions for the types of diets you should have if you are diabetic or obese? Are there any specific foods which help prevent it? And do vitamin and mineral deficiencies have anything to do with it?
Okay.
And I'll piggyback on that too, because we had
sure.
another question about that.
Sure. So there are a variety of diets that are very effective for patients with diabetes. The first thing is portion control. You need to look at your plate, more vegetables, protein, and a smaller amount of carbohydrate. What breaks down into glucose is any food that contains a carbohydrate, which can be something so obvious as any kind of starch, pasta, rice, potatoes, but it's also fruit. And even milk has carbohydrate in it. So you have to look at your carbohydrate content in what you're doing. There are a variety of different kinds of diets that work for different people. Low carbohydrate diets are very effective for some patients. Some patients do really well with what's called intermittent fasting, that you eat your food between a certain set of hours, say maybe 12 to 8, and then you don't eat after 8 o'clock until the morning. Some people do well with intermittent low-calorie diets, 1 or 2 days of 600 calories, followed by a more standard diet during the week. So everybody works differently. The trick is something that you can live with. It does not work to do something really extreme that you do for 2 weeks and then go back to what you were doing before. You really have to have something that you can maintain as a lifestyle. The Mediterranean diet is also a really excellent diet that's high in complex carbohydrates, lean
Oils
protein,
and fat.
oils and fats, low carbohydrate. The things there are.
And does it matter too what you eat with what?
Well, you always want to have a mixed meal.
Yes, right. Because if you just throw a bunch of sugar at yourself,
you're gonna have a high glucose.
Right.
So having going back to that plate with your larger amount of your complex carb vegetable, smaller amount of protein, smaller amount of carb. You want to have a balanced diet. Eating throughout the day is beneficial. Not
you mean like grazing?
No, like not
every
having
5 hours.
Not having grazing. Grazing can be a problem because then you're just sort of eating constantly. So then you can really consume a lot of food, and also your body needs to be able to deal with what you just delivered it and dispose of it before you give it the next. So if you're constantly grazing, you can actually keep your blood sugar really high all the time.
And you know what else people don't realize? I don't think that it takes 2 hours. Is that right, to digest a meal? So you can't, if you're fasting, for example, and you eat at 6 o'clock at night, you actually don't start the count until 8 o'clock. You know what I mean? Because it takes that long to digest the food.
Who knows?
You're not on the fasting diet.
No.
I interrupted your train of thought. And also, you pointed out too that it depends on the person how you're going to react to it. So sometimes it might be a hit or miss.
Right.
You have to try one diet and see how that works,
Right.
and if you can live with it, which is a great point. And then if that doesn't work, you switch it
Right.
up. So it
Right.
can be kind of. And then as you get older or things change hormonally or what have you, you may have to change it up again.
Absolutely. You know, you're not the same person when you're 35 as when you're 65. You know, and not everybody's diet works for you. You may have a friend who lost a tremendous amount of weight doing something, and it sort of depends on where you started. If you were doing not so bad to start with, you know, certain changes may not give you as much bang for your buck. And then also always integrating exercise. Exercise is key. That will improve your metabolism, so it'll take the calories that you're consuming and help you dispose of them more effectively. I was going to also say counting calories does help for some people too. You know, getting an idea, you know, measuring, getting an idea of how much you're consuming in a day also. And not all calories are equal.
Right.
You know, eating 1,000 calories of candy bars is not really the answer, you know, obviously. So you really have to look at the components of what you're
They're
doing.
like, we know that.
Yeah.
So would you say one of the most extreme diets, and you know, it's a buzzword for a lot of people, but the ketogenic diet, where you really just, I guess your goal, if you're on that diet, is to go into ketosis, right? But that's kind of extreme, right?
Right.
It doesn't have.
Right. The ketosis diet, you just have to watch. You know, sometimes that ends up being
And this is no carb. I mean, we're talking
it's no carb,
no
and
sugar.
also very high fat.
Yes.
So you have to watch that, because high fat diets can also have a negative impact in the long term. So you need to really keep a balance in what you're doing. And I personally feel that there's value in all foods, including the occasional candy bar. You know, speaking personally. So, you know, balance is the key. They have also found that people are less likely to be compliant with a diet if you are denying yourself things. So if you say, I can never have a noodle again, you're going to be craving that noodle.
Right, that's all you can think about.
You know, so it's being, lost the word. Just a little bit of everything. Being
Well, I think
moderation,
moderation and balance.
That's
right.
the word. Totally lost my
I
words.
think on that question as well, they had something about supplements, right? Are there supplements
yeah.
you can take? Did you ask about that could help the situation?
So that would be relevant, yes. The question specifically was whether mineral or vitamin deficiencies were relevant.
There are some vitamin deficiencies that are associated with certain medications that you can use with diabetes. So like if you're on metformin, B12 deficiency, a lot of individuals are also vitamin D deficient because we're not getting enough sun exposure. If you're eating a healthy diet, it's not likely that you're going to have a mineral deficiency that would cause diabetes. So I'm not quite sure where the question is.
But would it
coming
help if you were supplementing? Let's say, I would imagine you're having complete blood work on a
Sure.
relatively regular.
Absolutely. I mean, most people who are eating a healthy diet, eating some from all the food groups, is going to get a sufficient amount of minerals from their regular diet. Vitamin D is a very difficult one because you get that from exposure of sun to your skin. And so you can't, unless you're taking a supplement for vitamin D, if you're not getting enough sun exposure, that's one that you can't really consume just in food. There is D supplementation in some dairy products, but when they've done some studies, it's not necessarily consistent how much D is in your milk. So that's one that we often see. And some people may have, say, B12 deficiency because if you, some individuals have problems with their stomach and you need to have all the components that make you absorb B12 working properly. And that can be another vitamin deficiency that we can often see in individuals that we treat.
So we got a lot of questions ahead of time too, just knowing that we were going to be talking about this, and I want to go over some of those to make sure that these folks don't get overlooked. And we talked about eliminating sugar. Someone, Trina, asked if you eliminate all sugar from your diet. I guess that would almost take you down to the ketogenic. Can you prevent diabetes?
So, no.
You can, in other words, you can still get it if you're genetically,
Yes.
let's say, inclined, or
And it depends on how you're describing sugar. You know, sugar might be in like putting sugar in your coffee. but
Carbohydrates, let's
Right. So exactly. So we have lots of foods. If you ate smoothies all day that you don't add any sugar, but you're filling it with lots of fruit, that converts right into glucose in your system. So you have to look at really carbohydrate intake. Even if you did a carbohydrate-free diet, which I would never suggest because carbohydrates have good thing. You need glucose in your body because that's the fuel for your system. You just have to eat an appropriate amount that your body can handle.
So if you're trying to live a healthier life, and you eat a more balanced diet and you watch your portion control, is it safe to say that you may decrease your odds of getting diabetes?
Exactly. Being at a healthy weight, keeping sure that your body mass index, which is a reflection of your height and your weight, is in the normal range, exercising, all of these things reduce your risk of developing diabetes. And unfortunately, there are some patients even who do those things who still develop diabetes because it is, in many patients, genetically predisposed. So even under best circumstances, you may not be able to prevent it from happening.
And of course, I'm sure there are those people who are obese and they won't get diabetes. I mean,
Yes, it's not a foregone conclusion that
Right.
every overweight person is going to develop diabetes.
Another question, how much weight do I have to lose to make a difference? And I know this may be for a question for our next guest too, and,
Right.
and a number of people who are probably involved in helping this person, but when do you start seeing a difference, or is that individual?
It is individual, but studies have shown that even modest weight loss can significantly improve glucose control. So even 5 or 10 pounds can make a big difference. I have patients who are significantly overweight that may need to lose 30, 40, 50 pounds. And they look at this and they're like, I'm never going to get to that goal. And I say, start with your first 5 pounds.
Yeah.
That will make a difference. And I personally had done Weight Watchers in the past, and that's how they approach it. They don't say, your goal weight may be X, but they don't start with all of that. They reward you when you get to your first 5 pounds, when you get to your next 5 pounds,
Right.
when you get to 10%. You get all sorts of little rewards to make you
And not only that,
encourage
if
you.
you've lost 5 pounds, you feel better.
Right.
I mean, 5 pounds makes a difference.
It's a huge difference.
This is an interesting question. I've heard that diabetes medication makes you gain weight. Is this true?
It depends on the medication. There are certain medications that are associated with weight gain, and there are some that are absolutely associated with weight maintenance or weight loss. So there are many new medications that are out on the market that actually affect appetite and help you to lose weight. There are some injectable medications that are not insulin that are associated with weight loss. Unfortunately, insulin is associated with weight gain. So because it makes you take everything that you're eating, if you're giving the right dose of insulin, you get to keep it. So if you're eating more calories than you are burning, you are going to gain weight. So we would like to get people involved in the management of their diabetes before they get to that point so that perhaps we can put that off for longer.
This is where it really becomes an art, I feel like. Another question.
There we go. We're not going to have time for all the questions that I've been getting, but
We'll read really fast.
I want to jump back to the genetic component really quick. With all the improvements that have gone into gene therapy in the past few years, is that an option for treating diabetes, potentially even for in vitro?
Oh my, not yet.
What about identifying the gene?
There are many, many genes that are associated with type 2 diabetes.
That have been identified
Yes.
that you can be tested for?
There are studies going on to evaluate. We do not, on a routine basis, do genetic screening for diabetes. We're not at that point yet. There's actually there's a number of large studies looking at what genes are associated with certain forms of diabetes and identifying them. There are NIH trials, there are national trials going on about that. So, and it's unfortunately, the process of absorbing glucose is exceedingly complicated, and you can have abnormalities in a variety of places on the pathway of getting that glucose into your cells. So it's not just one problem, one cure. So that's why so many medications affect glucose control by working in different ways, because the dysfunction is so multifactorial.
All right, another question. I have prediabetes. We talked about this before we came on. I thought it was interesting. What do you think about liposuction to lose weight?
Liposuction will make you look better. It will not improve your insulin sensitivity. So it doesn't improve your glucose control at all. It will make you not have your
But you're getting rid of fat cells.
But
right?
it doesn't change the essential nature of who you are. Actually, exercise would do that. So liposuction won't fix your diabetes at all. It'll just make you look a lot nicer.
Okay, there's so many questions. I want to get to another one. After repeated blood sugar testing, do your fingers get damaged from repeatedly sticking yourself?
No. I mean,
And how often do your patients have to test their
testing
blood?
glucose? It depends on the patient. There's what we like, what patients are willing, and what Medicare will pay for. They're not the same. So if you are a patient that's on insulin and you need that information to decide on how much insulin to take, you would check your blood sugar before each meal at a minimum, or before each time you're going to take insulin. If you're on a patient who's on oral medication, I find that testing blood sugar at different times during the day gives you feedback to be able to help you adjust what you're going to do. So I sometimes have patients check several times a day, but at different times, so that we can get sort of a spread of how things are going, so that we can say, okay, you do pretty well after breakfast, but you really have a spike after dinner. Let's focus down on that time. And sometimes I tell patients, don't avoid checking your blood sugar when you've been bad. Check it then, and then you can see what have you done. And then if you adjust your diet, you can see, oh, I left out the dessert and my sugar is not 250, it's 160. So it gives you a lot more immediate feedback. The other thing that's available now, which is really a wonderful tool, is there are these continuous glucose sensing devices. There's one that's over the counter that is called the Freestyle Libra, which is a glucose sensor that you wear on the back of your arm that will track your blood sugar continuously. You have a handheld device that you hold up to it.
Oh my
and
God,
it
I'm
gives you
sure
a
it'll
reading.
be on your phone soon somehow.
There actually is I think there is a linked app with that.
Okay.
For Medicare patients, unfortunately, it's only covered if you're on multiple daily injections and you're already checking your blood sugars 4 times a day for them to qualify to give you this device. But you can always purchase it. You don't have, and then you'd pay out of pocket. For insurance carriers, they have been covering this device. And then there are other, that's sort of like the base level. There are other devices. There's a device called a Dexcom, which is a more integrated, more sophisticated device that alarms and gives you a continuous read. With the Libra, you have to take the device, hold it up to it to get the reading. It doesn't alarm. It doesn't tell you if you're dropping or you're going up, but you don't have to stick your finger to do that. And for a lot of my patients who really have been adverse, they might do something with their hands or type or something, or they just hate doing it. The Libra has been a game changer. For allowing them to see that number in real time and really make changes in their behavior and their eating habits.
We've run out of time, unfortunately. There's so much to cover, but I just want to give you a moment to say, what's the one thing you want to leave people with that you want them to know, or one misconception that you want to...
Diabetes is entirely treatable. It is a lifestyle. You have to look at all aspects of your life, your diet, your exercise, your stress, your sleep, your medication. You have to work with your physician and all the other people who are in your life to help you achieve a healthier lifestyle. And it's entirely manageable with aggressive care.
All right, and thank you for giving that aggressive care. Dr. Ruth Horowitz, thank you for being with us today.
Thank you.
And we're going to be talking about exercise more closely coming up. We also want to show you this video about how GBMC is really trying to help people deal with the problem of obesity.
For many people, controlling weight gain is a daily struggle, but with learning and support, winning that battle gets a little easier. GBMC is combating diabetes and obesity by starting with education at our primary care practices. Our team provides the resources and guidance patients need to live healthier lives. We offer individual counseling or group sessions to educate patients on how to manage their diabetes, from nutrition and meal planning to properly using medications. Our team works with individuals to coordinate a plan specific to their needs. It could be a radical diet change and incorporating exercise into their daily routine. Or if surgery is the right choice, we can seamlessly connect patients to the needed resources. Patients aren't just losing weight, they're gaining a ton of confidence. They're empowered and in control because of the support they receive. Intervention and education is what's going to keep our community healthy, out of the hospital, and at home with what matters most. What can GBMC teach you?
And welcome back to Greater Living. We've been talking about particularly type 2 diabetes that mostly affects adults, but recently we've seen an uptick in the number of children being diagnosed with type 2 diabetes as well. But we're talking about being an adult, developing diabetes, how you live with it, how you manage it. It is manageable. It takes a lot of work sometimes and a lot of sort of figuring it out and managing medications and your lifestyle, really. So a big part of living with diabetes, preventing diabetes, managing diabetes has to do with exercise. And some people are better at that than others. And some people really struggle because, as you pointed out, Joe, they're in pain. Joe Palmer is joining us now. He's a physical therapist with GBMC Health Partners Rehabilitation Medicine. And thanks so much for being with us and talking. So I can tell by looking at you that you obviously believe in exercise. You lift a few weights here and there.
I do. I practice what you preach.
right?
But health, and we should all be finding the time.
Right, and when you're dealing with diabetes and glucose levels and the blood, it's different forms of exercise too that really matter. Isn't that right?
So all forms can be beneficial.
Sure.
When really managing the glucose process glucose without insulin. So just using your muscles.
Someone described it to me as your muscles are like Pac-Men, right? So they're, if you don't have a lot, you don't have a lot of Pac-Men, but if you have, they're going to fix your microphone, right? You heard him, though. Our audience heard him. But we'll get back to that just to make sure. Yeah, hopefully they picked up on mine. But so they're like chomping away at the glucose, and if you have more muscle mass, right, that's more chompers to eat that glucose.
That's exactly right.
A little feedback. Right. Okay, so exercise is important. Let's talk about what you do at GBMC.
So GBMC realizes that people need to be active, and they want to help get that message into the community. I'm a physical therapist and co-owner of Active Life Physical Therapy, and we are working to establish a network of physical therapy sites within the greater Baltimore area for GBMC patients to use in order to help become more active, to manage their chronic musculoskeletal conditions so that they can participate in exercise without pain.
So along with diabetes, you must see patients with all kinds of issues, right? But I guess the commonality is that they struggle to move.
Absolutely. So we see all orthopedic issues. We have three locations in Perry Hall, Lutherville, and then we work as a small part of the Center for Rehabilitation Medicine. And so we see orthopedic there at the hospital. That center also specializes in lymphedema, pelvic health. We see patients that are going through cancer treatments and have specific programs designed to help them stay active as they go through those treatments. And so really any condition that deals with motion and activity. As a physical therapist, we are really a mobility expert, and we want to help keep people moving
and functioning in their life, right? Yeah,
absolutely,
and independent. I mean, it really translates to all kinds of things.
So as you, if you don't move it, you lose it, right? And if you start to realize that you're not able to do things that you used to be able to do, eventually gets to a point where you're not going to be safe to be independent, and right. And ultimately we want to try to get people invested in their health before they get to that point.
So let's say I've been diagnosed, let's say pre-diabetic or even diabetic, and I've been diagnosed with diabetes, and I'm in my mid-60s, and I haven't been to the gym in 15 years, and I know I'm a little overweight, but this is so intimidating to me, and I have no range of motion, but I know, according to my doctors, that I have to get moving to manage this diabetes. I mean, how many people do you see like that?
So we see a lot of people that have fallen off the exercise train, and they come in, and usually there's some kind of ache and pain that goes along with that immobility, and so we address that and then help get them on a program that they can either manage on their own at home, or manage at a gym, or manage at one of our facilities, which we have post-care wellness facility that helps. Once people do get moving, we want to do everything in our power to help keep them.
I would imagine there's a fear factor in the beginning too.
Absolutely, and we deal with that all the time. It's a fear of, am I gonna make my pain worse? I don't really know what to do. The fear of the unknown, and so.
And it's work.
And it is. You're investing time and energy into doing those things. And so, we help to take the guesswork out of it. And we're your coach. We're encouraging you to stick with it and be consistent.
What can you see happen? I mean, you can put together a bunch of stories of people you've already worked with, something anecdotal, but what can somebody who hasn't been to the gym, hasn't been exercising the way they should, hasn't been lifting weights, is dealing with diabetes, where can you get them?
So, what we see every day is the person that comes in that is unfamiliar with exercise. And as they start to move their bodies over the course of 6 to 8 weeks, by the end of that time, they feel like, man, this really does feel good. It makes me feel good. And part of that is a release of chemicals that you get when you do exercise, and your body responds to that, and it gives you like a mood adjusting.
So those would be one of the hidden benefits of exercise.
Definitely a hidden benefit of exercise is that it can increase and improve your mood. They've done studies comparing exercise to antidepressants. And taken people that are clinically depressed, and they've split them into 2 categories. One category got drug therapy, and the other category did aerobic exercise on a daily basis. And what they found was that the drugs kicked in a lot faster. They regulated people's mood very quickly. But at the end of a 16-week exercise routine, there was no difference between the people that worked out and the people that were on medications. And so exercise as medicine is so much bigger than we imagine.
Yeah, and I guess if someone sticks with you long enough, you can see that sort of elevation in their mood. Because if you've been diagnosed with a chronic illness, that can be depressing in and of itself.
And their pain is decreasing. So they're in pain. They're not moving as well. They have a lot of factors that as we go through our therapy, they start to improve. They can do more. All of those things help to increase.
Can you talk about the benefits too of seeing a physical therapist, especially right out of the gate? Instead of just going to the gym and your doctor says you need to exercise more and you're just going to go get a treadmill.
So a physical therapist is going to do a thorough musculoskeletal evaluation, and they're going to, based on your history and communication with you and your PCP, they're going to look at what is appropriate and where you should be starting, and we're about modifying a program so that it's unique to you. Not every program is going to be acceptable for every person, right? And so that especially as we age and have other comorbidities and things that are breaking down in our bodies, we want to make sure that the program that we start you on is going to be is going to benefit you and not harm you, and that's really when you get into doing kind of general programs or DVD type programs at home, things like that. It's certainly a good exercise routine and a good program, but it may not be good for you.
Yeah, because there's a fear factor there. If I come work with you, I'm worried, are you going to ask me to do something that I'm not capable of doing? So, but someone who's a trained physical therapist, you're well aware of that. You start small, I would imagine, right?
That is what we do, and the graded exercise approach is what makes us different than trying to self-regulate that at home.
How often should someone come to see a physical therapist, particularly if they're just getting started on an exercise routine to help manage their diabetes?
That is hard to say.
It depends on the person.
And so what I would say is, any physical therapist that you see is going to sit down, talk about your goals, and see what issues that you have that are going to limit you from getting to those goals. And then based on those limitations, come up with a plan. And so sometimes that may be that you see them once a week. Sometimes you may at first need to see them a couple times a week. and usually the goal is not to continue with that therapist long term, but rather to help you become more independent with
Get to a certain
with
place where you
exercise.
can take it.
Exactly.
Yeah.
Get you comfortable, and then transition you to either a gym facility or a home type program that you now feel comfortable with.
We talked a little bit with Dr. Horowitz about insurance and what they cover and what they won't cover. This is sort of the whole healthcare issue. How does that, in your mind, it's a question that came up, and I didn't know if you had an opinion about it, or how it's covered, or what emphasis is placed on what you do.
So, as far as insurance coverage, I think it is one of the big things that is wrong with our health system at this point, is that we're very reactive as a health system, meaning that
as individuals too.
But insurance, they cover limitations. So if you start to have limitations or have pain when you're doing activities, well then your insurance will start to cover physical therapy for that more than likely. But the reality is that prevention, trying to maintain and do the things that we need from an exercise standpoint to maintain a healthier lifestyle is not really fully covered by, and some insurance plans do have different options for coverage, but for the most part, it's a very
which, as we all know, in the long run, could save money, right? Of course, people.
Exactly. It's why you do your oil changes in your car, right? You do your oil changes because you know that if you don't do it, your engine could freeze up, right? And so we all spend money to make sure we do that little maintenance piece,
right?
And so it's not that different with us. We have to invest in our health the same way we invest in other things that we value.
So for people who may be listening or watching right now and they're saying, and they don't have a diagnosis of diabetes, or maybe they even are pre-diabetic, which is a huge wake-up call, but let's just say they have been living a more sedentary lifestyle, they're not eating as well as they should, and they're listening, they're like, I really don't want to get diabetes, I really don't want to be pre-diabetic, and I need to get exercising. So the big question is, how do I begin? In your opinion, what's a great way to start? I know that's an individual question too, but...
So I think the first thing is you should talk with your primary care physician. You should.
But they always say that, talk to your doctor.
So
right? I mean,
it's important. It's important for a couple of reasons. One, what you do want to make sure that they're aware that this is something that you've decided is important to you and that you're gonna start. And so they're gonna screen you for risk factors that may need modification or that may need to be addressed before you start an exercise program. They also may want to see you more frequently after you've started the exercise program, because as we heard with Dr. Horowitz, your exercise can affect your blood glucose, and it can affect how the medications that you're taking are working. So if you are diabetic and you are taking medication or insulin to help regulate your blood glucose, if you start a aggressive workout program, it may have effects on your blood glucose.
Yeah, that's where the food all comes in.
It
right?
may need to be your insulin may need to be modified in order for you to participate effectively.
Can you talk a little bit about your office? And I understand that you have what's called a healthy happy hour.
No.
Sounds like a very happy hour, and more than an hour, I might add.
It is more than it's more than an hour. What happy hour is really just an hour.
Exactly.
Exactly. But it was very fitting that we're doing this because we're having a healthy happy hour in our Perry Hall location. Our wellness director there, Courtney Ferreira, she is a registered dietitian, and she's also a personal trainer. And so on Thursday, March the 7th, we're inviting people to our wellness facility. There'll be healthy snacks as well as group exercise classes and nutrition discussions, question answer type forum for anybody that's interested in starting that wellness routine, or may have fallen off their New Year's resolution.
That was a long time ago.
and are ready to try again. We want to talk and see if we can give you some.
And people just pick up the phone and give you a call, or you have an online?
We have a Facebook event that will be posted in this session. So you can find us that way. You can call us. You can reach us on our website as well.
All right, Joe, thank you so much. And are all of you exercising regularly? Look at that. Love it.
Good.
It's a lifetime, right? You don't stop. You got to keep going with it and keep working on it. And
absolutely. It's something that it really is an investment in your health that you have to do forever.
No doubt, no doubt. Joe Palmer, thank you so much for being with us and talking about diabetes and the benefits of exercise. I just want to piggyback on what John said. Just a reminder, if you're watching us live right now, particularly, tomorrow on Valentine's Day, we're giving blood. It's a huge blood drive at GBMC in the conference center. It'll be going on all day. It's so easy, it's so beneficial, and it's so needed. I'll be there at 1 o'clock, so if you want to come say hi and share a cookie with us, and John will be there too. Apparently we're holding hands. I think he's a little afraid. Thank you for joining us today for Greater Living, and here's to you. It's great. Thanks.
How about another round of applause for Mary Beth?